Hello everyone and welcome to Arthritis Talks, Road to a Cure. I'm Dr. Sean Bevan, Chief Science Officer at the Arthritis Society, and I'd like to welcome all of you and thank you for joining us today on the final day of September and also the final day of Arthritis Awareness Month. Arthritis research has been a priority for the Arthritis Society since our founding more than 70 years ago. We are Canada's largest national funder of arthritis research, investing over $200 million in research projects since our founding. These projects have led to breakthroughs in the diagnosis, treatment, and care for people living with arthritis. We know from our many conversations with people living with the disease that research is an area of great interest, but it's also an area that often feels a little bit mysterious and sometimes complex. And that's exactly why we're here today. We want to break down those barriers and help make research understandable. Our panel of experts today will answer some of your most common questions about arthritis research. Thanks very much to those of you who have submitted questions in advance that have really helped us to get started. So before we get underway, just a few logistics. First, the webcast is best viewed on a laptop or desktop computer. If you have technical issues, please do email support@webcastcanada.ca for assistance. If you have questions for our presenters, you can submit them through the Q&A section at the top right of the screen, or you can email them to arthritistalks@arthritis.ca. We will do our best to try to get through as many questions as we possibly can during the next hour. You can click on the chat window on the right of the screen to connect with other participants and the Arthritis Society's chat moderator. If you'd like to close the chat completely, please click the icon on the bottom right of your live stream window to view the webinar in full screen. So let's get started. We, the Arthritis Society, is Canada's national charity dedicated to creating a world where people are free from the devastating effects arthritis has on lives. We do this by funding research, by advocating to governments on your behalf, and by providing timely, evidence-based information and support to help you live a good life. As I mentioned earlier, September is Arthritis Awareness Month, and throughout the month, we've been encouraging Canadians to join us in raising $1 million and 1 million voices for the 6 million Canadians with arthritis. These efforts are aimed at putting us on the road to a cure. I want to take a moment to thank our event partners, Amgen, Novartis, United Way Winnipeg, and the province of British Columbia. So now I'm pleased to welcome Dr. Diane Lacaille, Dr. Paul Fortin, and Dr. Hance Clarke to speak to us at today's Arthritis Talks. Our presenters are going to do their very best to tailor the information presented today to those of you watching. So with that, for those of you on a desktop computer, you will see our first poll question pop up, which should be on your screen. What type of arthritis are you most interested in? Osteoarthritis, inflammatory arthritis, or both? Okay, thank you very much for providing that feedback. So with that, let's get to the first question. This is a big question. So maybe I'll first ask Dr. Fortin if you could help us with this. What do you think have been the most important research advancements for arthritis patients?
Thank you, Dr. Bevan, and thank you to the Arthritis Society for organizing this event, and good evening, everyone. So certainly in my lifetime, there has been quite a bit of advancement in research, and I would say in the last decade, what has been a change, a transforming event is the evolution in the treatments of inflammatory arthritis. And if we take, for example, a patient that would come in with a new diagnosis of rheumatoid arthritis today, as compared to when I started my training a few decades ago, there's been a total change in philosophy. A few decades ago, what happened would be that we would have the person admitted to the hospital, usually for 2 weeks, and we would prescribe bed rest because we had very little options. And we would treat with injections of the joints that are inflamed with cortisone. And we would wait several weeks and start on medication like aspirin at very high levels, often levels that would cause side effects, and wait for a year or two. And if people did not get better on their own, we would then start what we would call a disease-remitting agent. And in that meantime, a year or two later, people would have developed damage to their joints, which would have an impact later on in their life. That was then. Today, through research, what we've learned is how the disease evolved, how it is very important to intervene very early after the onset of symptoms, usually if we can, within 6 to 8 weeks. And we would start with powerful drug, but efficacious drug that research has demonstrated that are very useful. So now a new patient would present to you with a diagnosis of rheumatoid arthritis. It would be all the workup done in outpatient. There would be no need to hospitalize, and we would be able to start treatment right away, usually with methotrexate and or another disease-remitting agent. And within 3 months, if there's no satisfactory evolution or response, we would then add a medication, usually some of the newer agents that are called the biologic agents. And we are now in this era where new treatments are being developed and approved yearly for rheumatoid arthritis that are much better in terms of targeting the inflammatory pathway that is involved in rheumatoid arthritis or in inflammatory arthritis and protecting the joints. So we have a patient that very quickly will respond, that will prevent the evolution of the disease, will prevent having structural damage, and also developing other conditions that could be associated with a long-standing inflammatory disease, sometimes cardiovascular disease that maybe Dr. Lacaille could talk to us about that, and also preventing them from losing their work and keeping a good quality of life. So in the last 10 years, certainly the pharmaceutical revolution has been with the development of these targeted drugs for inflammatory arthritis.
Thank you, Dr. Fortin. Dr. Lacaille, did you want to add to that a little bit?
Yeah, I'd like to pick up on 2 things that Dr. Fortin mentioned. I think one type of research that often people are not as aware of is what we call long-term epidemiological studies. And those are studies where we follow people for long periods of time. And the type of research that's really been crucial to changing the way we treat arthritis has been these long-term studies that showed us that when we treated patients the way Dr. Fortin just described, where our goal was to make people comfortable and reduce the pain, if we didn't completely get rid of the inflammation, then there were still long-term consequences that were really undesirable, like the joint damage and the joint deformities, the loss of work, and the shortened lifespan. But what we've been able to show in recent studies, for example, there are studies that I and other researchers at Arthritis Research Canada have conducted, and we were able to show that with these new approaches that Dr. Fortin just described, we were actually able to change those long-term outcomes, that we're no longer seeing the same increased risk of mortality. We're no longer seeing the same increased risk of other diseases like heart attacks and diabetes and lung disease that we were seeing previously that were due to that effect of the inflammation on other parts of the body. So I think this is really important advances. And I think another really other important advances are in the last decade, there has been a lot of emphasis on the fact that people with arthritis are at increased risk of things like depression and anxiety. We're no longer just focused on the biologic aspects of the disease. We recognize the impact of arthritis on other aspects of people's lives. Things, again, that have been mentioned, like people's ability to cope with their disease, the ability to work, etc. So what this has meant for the person living with arthritis is that there are now new programs and new resources that are available to people to help them better self-manage their disease, to address mental health issues. We, for example, have developed a program to help people stay employed. So these, when we think of research, we shouldn't only be thinking about research to develop new drugs. There's also a lot that has happened to help people live better lives with arthritis.
Absolutely. And Dr. Clarke, I know that you're coming at this from a slightly different research area. From your perspective, what would you say have been some of the most important research advancements?
Yeah, thanks for the question, Dr. Bevan, and thanks for the opportunity to speak tonight to the audience. What I would say is that, you know, you have the experts like Dr. Fortin and Dr. Lacaille who are on the disease modifying side of things and help patients along the journey early on. By the time they come and see me, it's really about quality of life, coping, some of the comorbid mental health things that Dr. Lacaille just talked about, anxiety, depression, and how we help these folks move forward. I'd say, you know, the biologics have been a real win in some of these conditions. And so I often tell the patients there's not much we can do unless you're actually on the appropriate therapeutic regimens. And knowing that, you know, that the hesitancy of some patients to start some of these medications, it's always a big barrier to jump over. I do know that in the pipeline, we're talking about, you know, some newer medications and on the pain side, some specific sodium channel blockers, such as, you know, NaV0.18 and things like this, where they're now potentially seeing a lack of cardiovascular side effects, but really good pain responses potentially. And so the pipeline isn't as grim as people have said from the pain side. And I would say that one of the things that the opioid crisis has done is it has really reinvested and reinvigorated research and development in pain and OA type medications that could have benefits long term. So, you know, all in all, the future is pretty bright.
Mm-hmm. Thank you, Dr. Clarke. I will say, to help our panelists here, we did get the survey results. So about 50% of our audience is interested in both osteo and inflammatory arthritis, and the remaining half, it's about 50-50 there too. So we've got a good audience here, and I think lots of relevant content for everybody. So with that, I think we'll go to the next question. Arthritis research has come a long way, and I think it's something that the arthritis community should be very proud of. We do hear a lot from people and patients that it doesn't seem quick enough. So Dr. Lacaille, maybe you could start. Could you just give us a sense of how long does it actually take to develop a new treatment?
I think it really depends on the kind of treatment that we're talking about. Generally, for new drugs being developed, we tend to say that from the bench to the bedside, so from the time in the lab of discovering things at the molecular level to having a medication that we're ready to use with patients that have been tested in clinical trials, it's about 18 years. So it is a lengthy process. And I also want to point out that even for non-medication research, developing interventions also takes time. And I think it's important to realize that good research takes time. Even for non-drug interventions, if we want to develop interventions that are based on evidence, it takes expertise, it takes a rigorous development process. We need to be testing it to show that it works well, that there's no unintended consequences. We need to make sure that we also test the implementation, which is how do we deliver this so that everybody has access to these interventions, that we remove the barriers. So really, you know, we have to realize that unfortunately, as much as we would like to get things out there quickly, if we want to have good services, it takes time. And so I was going to give an example. I talked about our Making It Work program before, and it took us actually over a decade to develop this program. And in order to show that it prevents work disability, we have to follow our patients for 5 years. So you can't do this overnight.
That's a great point, Dr. Lacaille, and it takes a lot to get something from bench to bedside very often. Yeah. Dr. Clarke, did you have anything to add there?
I'll just echo Dr. Lacaille's number of 18 years. It's certainly the number that I understand. And I did do some work in the pharmacogenomics and genetic space. Similar numbers, 15 to 18 years for sure.
Great. So I think I'll go to the next question. This is another very common question that we receive. Patients have a lot of questions about natural remedies, and it's often hard to find credible information about whether they're effective or not. Dr. Fortin, could you help us understand why is that?
Thank you very much for that interesting question. First, I'd like to reassure the patients that physicians also sometimes have difficulty getting the information they would like to have, and other healthcare professionals also are looking at the literature, what has been scientifically produced. So a reminder is that there is a fundamental difference between a natural product and medication. And that fundamental difference is in terms of regulation, because natural products are not usually derived from food and are under the regulations that are applicable to the food industry. So in the food industry, what is most essential is you have to demonstrate that what you're proposing on the market to consumers is that the food is safe. So the same principle applies to a natural remedy. The corollary to that, though, is that there is no requirement to have the person producing or the company producing the natural remedy prove that it is efficacious in certain conditions. So it is safe for the general population. It can be distributed and bought in on the market in Canada. On the contrary, for a drug, you need to not only show that it is safe, but you also need to demonstrate that it is efficacious. We've just learned about the time it takes for research to come to fruition, and it takes about 18 years. This is the average time it takes to prove that a drug is safe and efficacious for a condition, let's say, like arthritis. So the fundamental difference are regulatory, in that the natural remedies considered food, they will have to have studies showing that it is safe, but we won't know whether it is safe in a subpopulation. Let's say someone has an immune disease and you're taking a natural product that is reputed to boost the immune system. They don't need to show that it is safe in the condition that you have. And so it could have also a counter effect that we're not aware of. So that's why there always been a lot of hesitancy from healthcare professionals to comment on the usefulness or the efficacy of these medications, simply because there is no documentation and no research on that aspect of these products.
Okay, so it's relatively complex.
Yes.
Unless either of our other panelists wanted to add to that, I think Dr. Fortin, I'll add it to you for a second, leave it with you for a second. In the context of the pandemic, we certainly saw arthritis and arthritis medications in the news quite a bit early on. And of course, we want to know, how does COVID affect arthritis patients? So Dr. Fortin, could you give us a sense of what research is being done to help understand the connections between arthritis and COVID-19?
Thank you very much, Dr. Bevan. I'll start before relaying the speech to Dr. Lacaille and Dr. Clarke by talking about one project that is being conducted in Canada. The Arthritis Society has been instrumental in creating a network of rheumatic disease units in Canada that are academically based research center and teaching centers in the universities. And because of that experience over the last several decades, there has been the construction of cohorts of patients with arthritis that are being followed over time. And when something like a pandemic, like the COVID-19 pandemic occurs, there is suddenly new questions that are being asked, and we need to very rapidly turn around and try to find how we're going to get answers to the questions. So if we can have the next slide. I don't know if you have the slides on the co-viral project, but we have asked, we have determined an objective, which is to assemble a very large cohort of patients that are already being followed through Canada in asking what will happen about their response to the virus, to this new virus, the COVID-19 illness. And we have the advantage of being able to follow these people and having blood tests that have been drawn before that are associated with very important information. So we call this a library. We basically think of this as bookshelves with little samples of blood that are attached to a lot of clinical data on a computer. And so these informative biospecimens can teach us quite a bit if we follow the same people over time in those cohorts. So we will have the opportunity to follow up to 3,000 persons with rheumatoid arthritis and lupus and see what happens with their blood test over time in terms of reacting to the SARS-CoV-2 virus. One of the intriguing questions is, are patients with arthritis going to react the same as the general population? Are they more likely or maybe even less likely to develop severe disease because of their treatment or because of their immune function? We really don't know which direction it will take. So we have three objectives. We're going to first look at how many people seroconvert. So that means become positive for the antibody for the virus. We also, because it's been a lot in the news, are going to look specifically at hydroxychloroquine in this population. More and more in the general population, the studies are showing that hydroxychloroquine doesn't seem to give an advantage to people using it either before being exposed or immediately after being exposed to the coronavirus. But in patients that have used it for a long time, like our patients with arthritis, the story might be different. And we're also very interested in the impact this pandemic will have on the psychosocial aspects of this disease. So we'll look at that. I think Diane Lacaille and their team also in Vancouver are also doing studies. So
Dr. Fortin, what would you say?
Yeah, I think one of the area that in the next 10 years I really wish will be developing more is the patient-related outcome research. And I think we've been much more sensitized in the last 10 years about the importance of what patients' experiences are. And we are discovering arthritis is really a multi-dimensional illness. It is not just a joint disease. At the beginning of this conference, we heard Dr. Lacaille mentioning the comorbidities. What we mean by that is the associated illnesses that are increased in their risk with patients with either osteoarthritis or rheumatoid arthritis. The fact that their mobility is impacted, the fact that we've heard from Dr. Clarke that they have maybe issues more likely with pain, chronic pain leading to anxiety, to depression. So I think there's a great need of improving our research on patient-reported outcome and what they're telling us, and listen to what they're telling us. And that, I hope, will translate into research for developing better ways of helping patients making decisions. So the decision-making process for self-management, making the right choice because I, as a patient, I'm convinced this is what I must do, and I understand why I'm doing this. So hopefully that will improve choices, and the choices can be lifestyle. We've heard about an intervention for work to help people choose how to maintain their work activities if they have active arthritis, how to choose how, exercise might be much more important in 10 years than it is today in helping patients with arthritis. So that's my first wish, or my first crystal ball. What I see, I think will happen. I am also very interested in this multidimensional aspect of arthritis, and we unfortunately know that there is more risk of, for example, vascular disease or cardiovascular disease in people with inflammatory arthritis, and probably also even with osteoarthritis. So we need to understand more. And one of the ways we will understand this more is by looking at other players than just the usual inflammatory cells that we've learned so much about in the recent years. One area we're very interested in Quebec City is the platelets, which are interesting cells that normally were thought to only be useful to prevent bleeding. And more and more we're realizing that they may have an impact on inflammation, and especially on chronic inflammation. But this is just an example. We're going to be looking at other type of cells in the endothelials of the cell linings, the blood vessels, trying to understand what is the impact of chronic inflammation. And my third comment is reaching a little bit what was Dr. Lacaille's comment about precision medicine. By learning who is more likely to respond to maybe one treatment or another, that also allows us maybe to start thinking backwards and trying to identify who is at risk of developing arthritis, and maybe intervene much more earlier into the chain of events that will lead to arthritis, We know even now that sometimes we can measure markers of arthritis in someone before they develop their disease. So if we knew how to react to that and whether that person will be likely to develop the disease, maybe we could prevent that. But now that may be more than in 10 years. Well, hopefully not so.
It's certainly complex, but even just listening to the three of you, it's clear that Canadian researchers have a big role in what the future of this looks like. What you said about patients being involved in their own care actually leads very nicely into our last question before we turn it to the floor tonight. Dr. Lacaille, people living with arthritis are very generous and often want to get involved in research. So how can patients participate in arthritis research?
Well, I think there's many different ways in which patients can participate in research. The first most obvious one is as participants in the research itself. All our clinical research would not be possible if people living with arthritis weren't willing to participate in our studies. And this is not only participating in clinical trials where we're trying new medications, it's also a lot of our research involves people answering surveys or being willing to be followed over time or answering interviews, those kinds of research. So it's important for people to realize they might be a little hesitant to enter into a drug trial, but there's lots of other types of research that they can participate in. If people want to know how they can get involved in such studies, there's often websites that will be able to find out about studies that are currently recruiting. The Arthritis Society has, I believe, a tab where there are studies that are recruiting. They can find out about the studies. And at Arthritis Research Canada, we have on our website, we have a section of the website for studies that are currently recruiting, and people can find out which studies are currently looking for patients and how they can get involved. The other way that I also want to talk about is being involved in research as a member of the research team. So being engaged in the research process. And I think that the arthritis community has really been leading the way in terms of involving patients in the process of research. We have been doing this for quite a long time. And at Arthritis Research Canada, we have an advisory board called the Arthritis Patient Advisory Board. If people want to get involved, again, they can find out about it on our website. And similarly, across Canada, there's the CAPA, the Canadian Arthritis Patient Alliance. At IMHA, the Institute for Musculoskeletal Health and Arthritis, which is one of the CIHR institutes. There's also a patient group for patients to be involved in advising on research. So what I'm talking about here is patients that provide their lived experience with the disease, which is really, really valuable input into a research team that can help in the design of the study, can help in various aspects of planning the research, in terms of looking at things from a different angle that we as researchers tend to look at. So the perspective of the lived experience with arthritis is very useful in the process of developing the research, conducting the research, and in disseminating the research back to the community in a way that's meaningful to those who will be using the research.
Thank you for all those opportunities. So we have received a number of questions over the last 40 minutes or so. So let's see how many we can get through in the time that we have left. I think I'll start with a couple of questions about the pandemic, as it's clearly top of many people's minds right now. Maybe Dr. Lacaille, I'll ask you to address this first. And the question is, are immunosuppressed people more susceptible to get COVID? And how do they actually react when they get it? Do they get flares, stronger, weaker symptoms? What do we know about this right now?
So this is obviously a question that's top of mind for our patients and for us as clinicians as well. And it is the object currently of a lot of research. I've mentioned the 2 research projects earlier that are specifically looking at this. So I wouldn't say that we have all the answers, but certainly we're looking at this very closely. And with these studies where they have followed patients in many countries and large numbers of patients, and looking at the experience and how our patients with autoimmune diseases and patients treated with our various treatments fare compared to other patients. So far, I must say that the data is quite reassuring. It does not seem that our patients are at greater risk of getting COVID, and it doesn't seem that they get worse outcomes either. There are some medications that there is a bit of concern, and particularly patients who are on corticosteroids, especially at higher doses. Although it's interesting that at the same time, corticosteroids are used to treat COVID-19 once, if people are sick and have involvement of their lungs. It's also been shown that corticosteroids can actually improve the outcomes of COVID-19 in people who have the lung disease. So it's a little bit paradoxical, but that's what's
relay the microphone to her.
Yeah, that'd be great, Dr. Lacaille. Thank you.
Yeah, I think I would like to highlight 2 studies that I think might be of interest to our listeners. The first one is the Global COVID-19 Rheumatology Alliance. And I think this follows the line of what Dr. Fortin just mentioned, of really the need for mobilizing rapidly when there's a pandemic to get some answers quickly so that we can learn on a real-time basis answers to our clinical questions. And these are rheumatologists around the world that very rapidly mobilized and provided information on the patients with rheumatic diseases who have been to see their experience with COVID-19, so that we can understand the impact of medications and diseases. And the second project is a research by Dr. Avina, who's a scientist at Arthritis Research Canada, who received funding from the Michael Smith Foundation for Health Research, which is our provincial organization in British Columbia, to answer our patients' questions. How does the underlying immune diseases and the medications that we use to treat them, which often suppress the immune system, influence the risk of getting COVID and also the outcomes of COVID-19? So I think that those 2 studies are a very good example of one of them, which is a much larger number of patients, but getting less information on each one of them. And another study that will have more depth, because in this study, he will be able to have information from everyone in the province who test for COVID-19, and also linking this to information on medications and hospitalization. We're going to be able to look at the outcomes of the disease. So this is a very good example of how research can be used rapidly, harnessing data that we already have to be able to answer questions that are relevant to our patients and to clinicians.
Yeah, and if I could maybe just pick up on what both of you just said, it sounds like Canadian researchers and Canadian arthritis researchers were very well poised to establish a new direction as we looked at these new questions related to COVID.
Yeah, and I think Dr. Clarke also had mentioned that he had some very interesting research on COVID-19 as well.
Yes, thanks, Dr. Lacaille. So I think it flows nicely from both yourself and Dr. Fortin, because you're looking at the biologic markers, you're looking at knowledge mobilization. I'm seeing, unfortunately, a subset of my patients that were completely stable, and then COVID hit, and now I'm having requests for things like medically assisted death, immobility. They're not getting out and moving, and you know, unfortunately, we need to have not only knowledge mobilization, we have to mobilize resources to help folks cope from a mental health perspective. And so we were quite fortunate to you know, get a grant that's entitled Keeping Some of Our Chronic Patients Alive During and After the COVID Pandemic. And it really looks at a stepped care model for those that are struggling from some of the things you both talked about, the anxiety, the depression, all the things that goes with the immobility and being stuck in your confined spaces. And so we're looking forward. We've built a partnership with Alberta in terms of moving some of the step care model that we're building beyond just our local kind of Ontario infrastructure. And so we'll see how that goes over the next year.
Thank you, Dr. Clarke. If I could just keep it on you for a second, because I know, one of the tools you think about in your pain clinic is medical cannabis, and we certainly receive lots of questions around medical cannabis. Could you just help us understand, right now, what do we actually know about the potential of medical cannabis for the treatment of arthritis, and what are some of the challenges that you're seeing?
Sure, Dr. Bevan, great question. We know that cannabis is the hot topic du jour. 1 in 5 patients, we did a survey of about 600 patients that came through our hip and knee clinics presenting for their joint replacements, and 20% of those patients are using some form of cannabis product right now. When we dug a little deeper into some of that data. Typically, individuals that had ongoing chronic back pain, they had a history of depression, they had more than 4 areas of pain, or they had chronic pain issues for greater than a year, those were a significant odds ratio to be using cannabis. Clearly, the biggest predictor of someone who is using cannabis medically, and we haven't even got to whether it's been authorized by a physician or simply using a product from a dispensary per se, but that was the strongest predictor of anybody using it. When we looked a little deeper to see what patients were using, you'd be surprised in terms of the story out there with respect to CBD and it being the ubiquitous molecule that will heal and solve all of our issues and whatever we have in society. About 1/3 of that patient population was consuming a CBD product. The other 2/3 either were consuming something THC-based or had no clue what they were consuming. The average spend on a monthly basis was about $100. And I can tell you that we're certainly getting to a place where if individuals are finding effects from this, we now need to start to study and dive a little deeper as to what those effects and what those molecules are. We were lucky enough to get a CIHR grant funded, half by CIHR and half by the Arthritis Canada. So thank you for that. And it certainly is going to be a quite groundbreaking study. We are looking at patients that are going to present with all stages of OA. We are drawing blood samples. One of the things we know is everyone is looking for the new disease-modifying drug possibility. I can tell you that the chondrocytes in particular express a ton of endocannabinoid receptors. We will be taking chondrocyte tissues from people who are presenting for surgery and looking at whether or not those consuming cannabis have actually found any increased expression in some of those tissues. All of this will take time. It's, we talked about that 15 to 18 year road, but I will say that we're probably the furthest ahead of some of the other groups. We've just started our animal injection model based on our projects this week. And so we're moving in the right direction. And I think, as time evolves, we'll actually see what and which parts of this plant potentially have an effect long-term.
Thank you, Dr. Clarke. And we know that there has been a lot of progress in arthritis research, but we do have quite a long way to go before getting to that cure or cures. So maybe if I could ask the panel to think about what developments can patients expect to see over the next decade or so? And Dr. Clarke, maybe you want to continue and start off with that question.
Sure. I think, again, from an inflammatory perspective, we know that there are specific molecules and targets that if we stick with the cannabis road, we know that the CB1 receptors and THC in particular have effects on TRPV1 receptors, which have an effect on temperature regulation and then some of your nociceptive processes. CBD has effects far beyond inflammation on your serotonin receptors, dopaminergic pathways, the gut involvement with respect to some of these molecules. I think, the 5 to 10 year runway is appropriate. I think I touched on earlier, even some of the new sodium channel blockers that we potentially could see come to the market for OA patients and the TNF-alpha type medications. These are all promising developments, I would say, in the next 5 to 10 years for sure.
Okay, and Dr. Lacaille, what about your crystal ball? What do you see ahead?
My crystal ball, which I hope will come true, I think picking up on some of what Dr. Clarke just said about a better understanding of the pathways and the molecules that are involved in the pathways, I think that as we now are having more and more of these very effective treatments that are very, very targeted in their effect on the pathways, what we are still missing is knowing which patient should get which medication. And I'm hoping that over the next 10 years, what we'll see is some big advances on what we call precision medicine, where we are able to take a blood sample and see in this particular person what drives their inflammatory arthritis, and therefore which medications are they more likely to respond to. So that rather than going on a trial and error basis like we're doing right now, where we try one after another until we find the one that's right for the patient, that we can actually look at their inflammation and have a more personalized choice in the medication that they're more likely to respond to, so we find the right medication for the right patient. So that's my crystal ball wish for the next 10 years, which I think will make a huge difference for people. It's quite difficult making those decisions and quite intimidating to have to try to take various of these medications. So if we could get to the right one quicker, not only we would get better outcomes quicker, avoid potential side effects and damage to the joints, but also really, I think it would matter a lot to people.
Mm-hmm.
So far, the studies that have looked at people who were on steroids before getting the disease, there's a concern. But otherwise, our other medications to date, methotrexate and even our biologic agents, don't seem to be big risk factors for bad outcomes. The risk factors of outcomes in COVID-19 in our rheumatology patients are the same ones as in the general population. So it's things like age, high blood pressure, heart disease, lung disease, diabetes, that are the main determinants. So I think so far this is reassuring. And it may be that the more severe outcomes of COVID-19 are not due to the virus going into the different organs. They're due to the immune system reacting to the virus. So our medications that actually keep the immune system at bay may actually be helping our patients. And this may be why they're not doing worse. And I know a lot of our patients are contacting us and asking us, should I stop my medications? And our advice is, no, you shouldn't stop your medications, because if anything, you want to be keeping your immune system at bay right now. It's important for your immune system to be well controlled. And in fact, there's some of our medications that are being used to treat COVID-19 and that are currently under trial. So there's trials right now with some of our biologic agents that are ongoing. And we don't quite yet know what those results will come. There was some recently a trial with one of the biologics that blocks anti-IL-6 that at the last stage of the trial, unfortunately didn't show any benefit, but they're still ongoing, and that was in patients with mild disease. But there's ongoing trials used with an antiviral agent, remdesivir, and in more severe disease that are still ongoing that may show that it has some benefit. There's also ongoing trials with anti-TNF agents, and there's also a recent study that showed that one of the JAK inhibitors delayed the time to, shortened the time to recovery in patients with severe disease. So, there's lots of studies going on to help answer those questions.
Mm-hmm. We have a related question here related to vaccines. I'll just paraphrase a little bit, but the question, maybe Dr. Fortin, is really, will people with autoimmune disorders be able to be vaccinated for COVID if and when we have a vaccine?
Thank you, Dr. Bevan. Vaccine generates a lot of reaction, and there's a lot of beliefs about vaccine. But what do we know about vaccination already from other viral illnesses in our population? Well, in fact, we recommend highly vaccination, for example, influenza for the common flu in our patients with autoimmune diseases. There has been scientific evidence that not only does it not trigger increasing in disease activity, but it does not seem to be associated with worse reactions. And it ensures some protection. And that's what we want. We really want to be protected against an illness, an infectious illness that could be worse because of our disease. In fact, one of our researchers in Canada, Ines Colmenia at McGill University, has already worked on and published results from data in patients with rheumatoid arthritis being vaccinated for the flu vaccine. And those results were very reassuring. So that being said, what about a new vaccine for the COVID-19, the SARS-CoV-2 virus? All evidence at this point of the vaccines that are being tested suggests that this will be a vaccine where there is no living viruses. I'm making that point because vaccines can be of two types, if we make it simple. It could be only a vaccine that is created by some of the proteins that are extracted from the virus, but there's no virus left into the vaccine that is being injected to you. And that is what looks like the vaccines that are in development now for COVID-19 will be like. There's another type of vaccines where the virus has been tamed or attenuated that are sometimes being given from very few viral illnesses. But if you remember the H1N1 epidemics, that was one such vaccine. There was quite a bit of concerns, I would say, about giving it to people with a deficient immune system because there was still a virus that was alive. But this is not the case for the vaccines that are being developed right now for COVID-19. So all in all, we will most likely, we'll have to see, but we will most likely recommend vaccination for the coming COVID-19 vaccines.
And just while we're on vaccinations, we've had a few questions in the Q&A about should arthritis patients right now be getting the flu shot?
Absolutely.
Definitely.
This is the general
Definitely.
Great. There's also been a lot of talk actually about biologics, and Dr. Lacaille, you mentioned the newer JAK inhibitors. Maybe Dr. Lacaille, could you just give a very brief explanation of, how are those JAK inhibitors different from biologics that people would know about? And there's some follow-up questions about, is it normal for people to switch between biologics? Are there any particular concerns people need to be thinking about right now with COVID and the biologics that they might be on?
So yeah, I think there's a little bit of confusion for patients. JAK inhibitor, is this a biologic or not? So what the JAK inhibitors and the biologics have in common is that they are part of these very targeted treatments that target a very specific part of that autoimmune reaction that causes the disease in rheumatoid arthritis and in other inflammatory arthritis. So they're in the same broad category of medications of being very effective because they're very targeted and generally very well tolerated. They're not per se a biologic because a biologic by definition means that we're not able to synthesize this molecule biochemical process, and we need to create it biologically. So the biologics are cells that create the antibodies, and that's the process by which you create the molecule. So no, they're not a biologic, but I would say that they're like a biologic in terms of their effectiveness and the targeted action. And the big advantage is that they can be taken orally, whereas a biologic, if you would take it orally, you would digest it and it would be gone because it's a protein. So the biologics have to be administered by injections or by intravenous. So that was the first one part of your question. I think you also asked about the wide variety. I think it's very exciting that currently we have multiple medications that are out in the market and that are in the pipeline that are targeting different parts of the immune system. And I think this is a strength of the current approach. But what it means for the patient, though, is that sometimes we have to try multiple biologics before we find the right one that's the right fit for the patient. That is not unusual, and people shouldn't give up hope. And because one biologic didn't work doesn't mean that the next biologic won't work. And it's a matter of finding the right one that is effective in each patient, because we realize that the disease is very different from person to person. And what drives my immune system might be different from what drives the disease in another person. So that's where my crystal ball hope for the future, that we're going to be able to choose, have more information to choose which one might change that.
Mm-hmm. Thank you, Dr. Lacaille. Dr. Clarke, we have somebody here sharing a personal experience around trouble accessing medical cannabis, but the question really is about what evidence is currently lacking for physicians to be more comfortable around thinking about it as a potential for their patients.
Well, Dr. Bevan, that's a great question, and I'd probably be remiss not to mention the work that we're trying to do with the real-world evidence and bringing at least a national repository of data. And so there's a couple of things to help get physicians engaged. I know patients are having trouble accessing unless they dive into the quote-unquote cannabis world or the cannabis prescribing world. And so we have the Canadian Consortium for the Investigation of Cannabinoids are about to put out a CME by some of the brightest basic scientists, physicians that have been working with cannabis for the past 3 decades, both to give information on the adverse effects, the potential harms, the benefits, et cetera, and put it all in one nice CME bundle. And that hopefully will be coming in October. But the real world evidence that we launched with, I have to be careful because obviously there's a commercial entity associated with that, and it's through Shoppers Drug Mart. But what we have done there is that any physician in Canada that wants to at least give their patient a shot at having a product that has been third-party validated, and yes, to believe it or not, 7 years into an industry, this is the first time that if you order something, you will have a third-party analytic test to know that what's in the bottle is actually what you've ordered. And so the reason that this platform was built, and one of my thoughts, putting this together, was so that if I'm a physician, I'm going to be certain that if my patient gets a benefit from this product, they can go back into this and get the same product the next time. And that's been a real problem with patients accessing and physicians not even feeling confident about dipping their toe into this water. And so if you're in Ontario, you can certainly reach out to my center at UHN. If you're in, I think, BC, there are a couple of places there that have knowledge about the study and the products. But it really is to how do we engage the average physician? And if I'm a physician and I'm thinking about, these 2,000 patients or the cohort we're trying to put together, why wouldn't I want my patient to try one of these products that I can know exactly? Each product has been NMR tested, so nuclear magnetic resonance tested. This is a food industry standard to know exactly what's in each of these products. And so we can start to get a signal. If we had 800 of these 2,000 patients were osteoarthritis patients or RA patients, we then have those signals to say, hey, here are the potential products that we have available. And so we are working on that. It is a big push, but you hopefully over the next, my crystal ball over the next 2 or 3 years, we'll see more docs feeling a little bit more comfortable given the access to these products that are there. But again, it must be prescribed or authorized, via physician in the portal for a patient to have one of these validated products.
Okay, thank you. So I know that many of our viewers tonight are interested in osteoarthritis, so I want to make sure we leave some time to cover off some of those questions that have come in. So a few now. First question around, when does osteoarthritis normally start? Does it normally start at a young age, old age? What would you normally expect? Dr. Lacaille, maybe you can help us with that first.
Yeah, I think that's a very important question because there's often a misconception that osteoarthritis only occurs in elderly or after the age of 65, whereas in fact it commonly occurs before that age. So I think we always talk about breaking the myth that arthritis occurs only in older patients. And it's definitely for inflammatory arthritis, it can occur in younger age, but in osteoarthritis as well. And particularly in people who have had sports injury in their youth, they are at greater risk of developing arthritis as quickly as 10 years after having had the injury. So if you've had your injury in your late teens or early 20s, you get arthritis in your early 30s. So I think there's no age for developing osteoarthritis, but it is more common as people get older, more frequent after the age of 50, but it can occur before, especially in people who've had injuries.
Okay. And maybe Dr. Lacaille, could you give us a sense of what new research is happening in particular to help osteoarthritis? And we've had some questions that really focus on cartilage replacement. Is there any research being done there?
Okay. So there's a few different parts to your question. There's a lot of research going on in osteoarthritis, and I think Canada is actually very active in that sphere. I'm going to first speak to the research that I know best, because it's the research at our center, at Arthritis Research Canada. We have a scientist, Dr. Sibert, who has been looking at ways of detecting osteoarthritis early on, so that we can intervene early on to prevent the further progression of osteoarthritis, because often people get diagnosed very late once their joint is very damaged. We also have another researcher, Dr. Whitaker, who works on preventing osteoarthritis. We always like prevention, and we say prevention is the best medicine, and particularly in patients who've had sports injury in their youth. As I've mentioned, it increases the risk of getting osteoarthritis afterwards. So her research is looking at how can we prevent youth after an injury from getting osteoarthritis through better rehabilitation, through proper return to sport, etc., so that we don't end up with the outcomes of needing a joint replacement later on in life. I'm also aware that there's a lot of research going on. You've talked about cartilage repair. This is a very hot topic in osteoarthritis. Can we use stem cell transplant to regenerate the cartilage? And there's a lot of research going on this. It's not ready for prime time yet. But there are teams working on this across Canada, and hopefully this is going to be an option in the future, which ties into another question that's been asked as to, are there options other than joint replacement? So I think that in relation to that, I think right now there's a lot more than joint replacements that are available for patients with osteoarthritis. Probably the most important thing that patients can do is one, maintaining a healthy weight, because we know that increased weight puts increased strain on the joint and further accelerates the progression. We also know that the body fat releases inflammatory markers that further accelerate the damage in the joint. So there's a lot of benefits from maintaining a healthy weight and losing weight if people are overweight. Maintaining physical activity is also extremely important for people with osteoarthritis. And there's a lot of programs and a lot of resources to help people remain physically active. It's a challenge because if your knee hurts, it's fine for your doctor to say, remain active, go exercise, go and work out. But if it hurts, it's hard to do. So there is research, and again, we have a researcher at Arthritis Research Canada, Dr. Linda Lee, whose work is specifically around enabling patients to remain physically active through monitoring people's physical activity with a Fitbit-like apparatus and counseling from a physiotherapist, because we really need to, it's not enough to just tell people you have to exercise. We need to enable patients, to give them the tools that they need to be able to be physically active and to overcome the barriers to being physically active. So there's a lot of research in that area as well. And I think what there's also a lot of research, and I'm hoping that we will see some definite outcomes in the next decade, again with that crystal ball, is in seeing for osteoarthritis what we've seen in the last decade for inflammatory arthritis. So how we have disease-modifying agents for rheumatoid arthritis, there's a lot of research to find similar treatments for osteoarthritis. And there were some that were promising, but unfortunately at later randomized clinical trials didn't pan out to work. But I know that there's a lot of other drugs in the pipeline that are currently being investigated. We're also learning a lot more about the pathogenesis. So what is it that causes osteoarthritis, so that we can then develop drugs to specifically target the molecules that are necessary. So there's a lot going on for osteoarthritis. That stay tuned for what's going to come out for patients with osteoarthritis.
Thank you, Dr. Lacaille, for painting that hopeful picture for the future for osteoarthritis patients as well. That does bring us to the hour, so I just want to make sure to thank Dr. Lacaille, Dr. Fortin, Dr. Clarke for sharing so many incredible insights with us today. If you did not hear your question asked, please do email us at arthritistalks@arthritis.ca, and we will do our very best to have them answered. The video and presentation slides will be emailed to all registered participants this weekend, and the recording will be posted to our website very shortly. We would like to take just a few extra moments to get your feedback on today's presentation. So if you could please look at the poll that will come up for many of you and click on the response that reflects your thoughts. And the question is, did you find the information in today's webinar helpful to you? We will be sending an evaluation form when we send out the video. So if you can't access the poll questions, you will certainly have the opportunity to give us some feedback. Once again, thank you to Novartis, Amgen, United Way Winnipeg, and the province of British Columbia for their financial support of this event. We invite you to support us as we raise $1 million and 1 million voices this month for the 6 million Canadians living with arthritis. If you'd like to learn more about the research being funded by the Arthritis Society, please visit arthritis.ca/research. Many of our efforts are focused on sparking new ideas and new careers in arthritis research, and we really do look forward to continuing to support advancements in arthritis research for years to come, and invite you to help us do so. Our next event, Arthritis Talks, Managing Inflammatory Arthritis, featuring rheumatologist Dr. David Robinson, is coming up on October 27th. If you'd like to sign up for that event, please do visit arthritis.ca/arthritis talks. This concludes Arthritis Talks, Road to a Cure. On behalf of all of us, thank you for joining us today, and do please stay well.